So now I'm going to talk a little bit about hypertension. Hypertension is high blood pressure in the arteries, and it is typically measured in the brachial artery in the arm and is represented by two numbers. One, the systolic blood pressure, which is measured when the heart's contracting, and the bottom number, which is the diastolic blood pressure, which is measured when the heart is in diastole. The definition of hypertension recently became a little more rigorous than it was in the past, so I want to point out that normal blood pressure is considered a systolic pressure of less than 120 and a diastolic pressure of less than 80. If you have an elevated systolic pressure between 120 and 129 and your diastolic is still less than 80, then that is considered elevated blood pressure or pre-hypertension or borderline hypertension. Stage 1 hypertension is having a systolic between 130 and 139 or a diastolic between 80 and 89. And then stage 2 is a greater than 140 over greater than 90. Note that the higher number determines the stage. So if you have 118 on the top and 88 on the bottom, it's actually stage 1 hypertension because the 88 buys you this categorization. Of course, you're looking at multiple blood pressures over time, but you don't want to just dismiss this blood pressure because the top number is normal. Similarly, if you have a low diastolic and an elevated systolic, it still counts as hypertension. So if someone consistently is in the 140s over 70s, they actually have stage 2 hypertension. So the reason we categorize hypertension is it helps us determine when and how to treat the patient. So we treat patients more aggressively if they have higher blood pressure and also if they have other risk factors for heart disease, stroke, etc. Most of the time, hypertension has no underlying cause that we know of, and so we call it primary hypertension. A synonym is essential hypertension. That's kind of an older term, but it is still ubiquitous. The risk factors for developing essential hypertension are aging, obesity, unhealthy diet, sedentary lifestyle, and it's very, very common. So hypertension affects about 30% of U.S. adults, and it's a major contributor to all sorts of diseases that result in morbidity and mortality. And we'll talk a little more about that later. About 10% of the time, you can identify an underlying cause of the high blood pressure, and that is called secondary hypertension. I would draw your attention to table 11.3 in Lange. And the big things to point out are that kidney disease is a major driver of elevated blood pressure. It's kind of a vicious cycle because kidney disease can worsen high blood pressure, but then at the same time, the high blood pressure damages the kidneys. Most commonly, there's parenchymal disease, so chronic kidney disease, probably the most common cause of kidney-based secondary hypertension, but there's also renovascular disease, so atherosclerosis or fibromuscular dysplasia. There are endocrine causes of secondary hypertension. Probably the most common one we see is hyperaldosteronism, primary hyperaldosteronism. And then even medications can cause high blood pressure or worsen high blood pressure. For example, oral contraceptive pills, NSAIDs such as ibuprofen or naproxen, decongestants, and even some antidepressants. So look at the table, but these are really the big three that I wanted to call your attention to. So why do we care about high blood pressure? Number one, it's super common, and number two, it really is a huge contributor to all sorts of diseases. One of the ways it does this is by damaging the lining of the arteries. So there's endothelial cell damage, and then the other way is, so we have arterial damage over here, and then the other way is it just increases afterload, which stresses the heart. So this is a figure from Lange. And the main thing to look at here is the end result of hypertension, right? So increased afterload can result in heart failure. Both systolic and diastolic heart failure can be caused by increased afterload over time. And then the arterial damage can lead to MI, ischemic stroke, aneurysms, so abdominal aortic aneurysm, thoracic aneurysms, aortic dissection. Of course, there's hemorrhagic stroke, which if you have arterial damage and then a very high blood pressure, you can get a hemorrhagic stroke. And we talked about kidney failure as being both a cause and a result of hypertension, and then damage to the eyes. And these are just the major ones. And this is why we primary care doctors get really actually maybe a little overly excited about hypertension. First of all, it is one of the vital signs and it's there for a reason. And number two, we tend to often overlook it, I think, if patients have other things going on, but it is a driver of long-term disease. So every 10 millimeters of mercury that we can get their pressure down, we decrease their risk of major adverse cardiac events by 20%, and we decrease their risk of heart failure, we decrease their risk of mortality. So it's very, very impactful for our patients to adequately treat their blood pressure. So how do we treat it? It depends on how high their pressure is. Again, this is like an average. These are average pressures. You're kind of glancing at all their blood pressures over the last several weeks to months, and sometimes they bring in their blood pressure log. And we won't go into too much about the specific medications, but remember that lifestyle changes we should implement really for all of our patients, but especially if they have an elevated pressure or hypertension. So they should exercise, eat more healthfully, reduce salt in their diet, try to lose weight. And then we do utilize medications in stage 1 and stage 2 hypertension. So stage 1 hypertension, if they are really otherwise completely healthy, they don't have any medical problems, they just have this elevated blood pressure, you really can start with lifestyle changes and see if you can get their pressure down into the normal range without medications. But if you've tried that and it really hasn't worked and they're just persistently hypertensive, or if they have other things that increase their atherosclerotic cardiovascular disease risk, then you need to implement medications. You don't have to know the details about when we do this, and we won't try to trick you or anything. Patient has diabetes, or they have already had a heart attack, they've already had a stroke. Those patients are clearly at elevated risk, and we would add medications to the lifestyle changes. If their pressure is consistently in the stage 2 hypertension range, then we do use medications in addition to lifestyle changes. Generally, the medications we reach for first are either a thiazide diuretic, calcium channel blocker, or an ACE inhibitor or ARB. So some combination of these. It really kind of just depends on the patient and their preferences, and if they have other underlying conditions that may make you predisposed to prescribing one versus the other. And we're going to cover that in more depth. So that's it. Hopefully that gives you a good overview, and please come to me if you have any questions, or Dr. Shaw. Thanks.